It comes to thinking about immune manipulation. I mean, we've already talked about lenalidomide, but there were two kind of approaches we heard about today. One's putting your foot on the accelerator with the CAR cells, and the other one's taking your foot off the brake with the checkpoint inhibitors. They're both looking very interesting in the lymphoma field. You could argue, of course, the CAR T cells remain rather a kind of boutique type approach with a relatively small number of centers still able to monitor it. But we are starting to see quite durable responses in lymphoma, not necessarily as good as we see in acute lymphoblastic leukemia, but some of the diffuse large B-cell lymphoma data is beginning to look very interesting with that approach, don't you think?
Yes, in fact, at our center, we actually started some of the very original CAR studies, and James Corican, who was leading them, actually have taken a number of patients that were refractory large cells. In a number of cases, they were what we call primary mediastinal large cell, a disease of young people and people who really were at the end of their rope, and a number of these patients are now in durable CRs. So I think there's little doubt that CAR T cells will impact favorably outcome. What I think we don't know is we don't know who really will have a long-term benefit from these. And I think that's key because I think it's still at the end of the day going to be a minority of patients. Obviously these are new. They're still trying to work out the best way to generate them, numbers to give, targets, et cetera, et cetera. But I think that with all therapies in pretty heavily pretreated patients, it's only going to help a minority. And this is particularly key for CAR T cells for three reasons. Number one, I think they're always going to be limited in where you can get them because they're highly specialized. They're therapies that have to be generated for each patient, so they're going to be costly. And they are not without side effects, and they're not without lethal side effects. In fact, they have a relatively high rate of causing neurological toxicity, and there have been patient deaths from them. So I think they're a very exciting area, but right now I don't see them as being this broad cure-all for aggressive lymphomas. I think that they probably will have probably a better long-term outlook for diseases like CLL, and perhaps that's good because allogeneic transplant's good for CLL, but it really can only be used in very fit younger folks, and we know CLL is a disease of older folks. So I think a very exciting time, but a lot of people are jumping on the CAR bandwagon, and I think that's good. It should hopefully accelerate our understanding and perfection of this therapy, but I think the jury's out as to whether or not this is going to be a highly successful salvage therapy for aggressive tumors.